কি তুষার ভাই শুরু করেন।
Sure, শুরু করেন।
Assalamu alaikum, respected physicians. Welcome you all in today's presentation session. Today is the 106th session presented by none other than eminent Dr. Rafique Ahmed sir. And topic of today's presentation is atrioventricular block. Before start of the lecture session, I'd like to request Professor Chowdhury Ahsan sir to say some word about Rafique Ahmed sir, and then we proceed. Ahsan sir.
Oh, this is definitely a distinct honor and privilege to introduce Rafique Bhai. Rafique Bhai doesn't need any introduction. We call him the guru and probably the father figure of developing electrophysiology in Bangladesh. Rafique Bhai makes EKG or ECG simple, explains the EKG in simpler way, but he also addresses the complexity of the EKG and the electrophysiology. And I also enjoy interacting with Rafique Bhai, of course, and we fight with EKGs and then we go for a cup of coffee. Rafique Bhai.
Good morning. Sorry, a little bit of technical glitch here. So I'm going to talk about, it's a simple topic, but we need to know about this. AV conduction problem and basic, a little bit of physiology. So this is the conduction system. I mean, I always show this picture. Looking from the top, we can see the right atrium, left atrium, right ventricle, left ventricle, sinus node, which is in the top right corner of the heart. It's a pretty big structure. It's about an inch long. And then there is atrial tissue, the AV node, his bundle, right bundle, left bundle. Look at a little bit better way. If we look at from the right side, again, we can see the sinoatrial node. As you can see, it's a fairly big structure. And then the atrial tissue. And some people believe that there is some conduction, preferential conduction in the atrial tissue, which is difficult to prove electrophysiologically or histologically. And then we have the AV node, which is shown in yellow, and then his bundle, right bundle, and the Purkinje fibers. The AV node has been shown as a complex structure here, but people who are involved in electrophysiology, we know that it's not as compact as it is shown. There are a little bit of branches and trabulation here. If we look from the left side, this is the left bundle, and we need to pay attention to the left bundle more and more because we are now getting into the era of left bundle pacing. As you can see, the left bundle is a pretty wide structure, and then it splits into left anterior fascicle, left posterior fascicle, and some people believe there is a middle one. And as you can see, this is a very wide structure. So when we do left bundle pacing, it's pretty easy to hit one of these branches. So this is the ECG, well known, and P wave, QRS complex, QT interval, and then this is the PR interval from the beginning of the P wave to the beginning of the QRS complex. And that's where we're going to focus today, just this part. If we take the heart again, as you can see that the conduction, this is the P wave, and this is the PR interval, which is isoelectric line. AV node conduction actually starts pretty early on when the P wave is just forming. And this part, early part of the isoelectric is through the AV node conduction. And then when it is a silent flat line, conduction through the His bundle, bundle bench block, and Purkinje fiber. And once it reaches the myocardium, then we start seeing the electrical signal again. If I do intracardiac ECG, if I put a catheter in near the His bundle area, we can record the atrial signal, and then we can record the His bundle electrogram, which is here. And that means the time that needed from the beginning of the P wave to this His bundle is the time needed to go through the AV node. And then there is a flat area, isoelectric line, and then we have the QRS conduct. That's the time needed to go through the bundle branch and Purkinje fiber. So AV node, the autonomic nervous system, controls the heart. And the AV node, his bundle, and including the sinus node, they have rich innervation of cholinergic and adrenergic fibers. But the supply to the AV node and the his bundle is far more than in the ventricle. That's why it's important to understand this, because when we give atropine to patients, if there is a junctional escape bit, if there is sinus node, the rate will increase, but the ventricular rate will not increase much. His bundle is fairly immune to stimulation of the vagal nerve. That means if I do vagal nerve stimulation, if I give anticholinergic drug, the HV interval, this interval will not change. So if I give this patient atropine, this will get short. This will not change because there is not much effect of sympathetic and vagal stimulation on the his bundle conduction. Vagus nerve is cholinergic, but it modulates its activity by controlling the release of norepinephrine. Right vagus nerve affects the sinus node more, left vagus nerve AV node. And you can see this, like if you do cardiac sinus massage, you will find that in AV node reentrant tachycardia, it is more effective when you do the cardiac sinus massage on the left side than on the right side. Minimal effect on the ventricle, vagus nerve, and sympathetic nerve, of course, can increase contractility of the heart. AV block, different types. First degree, second degree, type 1, type 2. Many names, Wankaba AV block, Mobius type 2, second degree, and then third degree AV block. And there is a term that we all use, and it's now in the books of the high-grade AV block. If we find that there is a patient with 2 or 3 non-conducted P waves followed by a conducted P wave, we call it high-grade AV block. Etiology: congenital heart block. Diagnosis should be in utero or first month of life. So that is the definition.
Sir, can I interrupt for a second? So
Sure.
there is a term 2:1 AV block, which does not fit into anything. You haven't mentioned, just for the
I'm going to come to that.
learning
Yes.
point of view.
Yeah, I'll come to that. The question is, we use a term called 2:1 heart block. If I go back, I'm going to come to this. I think once I go a little bit more, remind me of this again in a few minutes. So acquired AV block, progressive conduction system disease, ischemic heart disease can cause it. If somebody has an anterior myocardial infarction, it can damage the conduction system. And we know that people who have inferior myocardial infarction can develop transient AV block because of damage to the blood supply to the AV node. Inflammatory disease like sarcoidosis, granulomatosis in Bangladesh, tuberculosis should be an issue. In United States, especially place where I live, not where Hafiz lives. Hafiz doesn't have Lyme disease, but we have Lyme disease. In northeastern part of the United States, it's a spirochetal disease and it can cause AV block. But if we give antibiotic, it resolves. So we are very, very careful. Anytime we get a young person or somebody who goes hunting, fishing, we always look at Lyme disease before we put a pacemaker in. And of course, infiltrative disease, amyloidosis, drugs can cause, if it is high dose, post-cardiac surgery, you can develop AV block. TAVR, about 15-20% of patients with TAVR can develop heart block. And then alcohol septal ablation. We get some patients with high vagal tone. We have young patients. Recently, I have 2 young females, 32-year-old and 42-year-old, intermittent dizziness, but have intermittent high-grade AV block. I'm not putting pacemaker in that person. I'm going to wait on that person to see if it resolves. So first degree AV block, simple. Everybody knows this. We have this patient, heart rate 56. You can see the PR interval is 324 millisecond, QRS 96, the first degree AV block. It becomes a little difficult to identify anybody. It will be tough to get some participants, right? But anyway, so this one, if you look at it, looks like a junctional rhythm. But if you look carefully, you'll find that there is something here.
There's
In
a P on the
T. Yep.
Sir, Roger will see. Sir, there's a P on the T in the rhythm too.
Exactly. So, and in rhythms too, we can say that. Now, the question would be, if you suddenly give this ECG to a young doctor and he says this is a junctional rhythm with U wave, I'm not going to shout at that person. I'll say, look a little bit more. So this in lead 2, it can look like a U wave. But if you look at lead V1, it looks kind of biphasic T wave. Even then, somebody may challenge me, and then I'll probably pull up an old ECG on this patient and to see if there are other places. But if you look at lead 2, you can see it's a little sharper wave than compared to. So this is a marked first degree AV block, not causing any problem to the patient. So where is the delay? So first degree AV block, basically, the PR interval is prolonged. So your delay can be in the AV node, it can be in the His bundle area. Most of the time, it's in the AV node. So like this patient, PR interval is 320 millisecond. If we put His bundle catheter, you can see the atrial signal. AH is prolonged, 250, HV is normal. So this patient's first degree AV block is due to slowing of the AV conduction. And this can be due to high vagal tone, or some people just gradually the AV conduction deteriorates. But most of this, if you exercise them, the AH interval would get shorter. Is it always true? So this is what it is. I put a His bundle catheter. The delay is in the AV node part because this is the His electrode. After His, the interval is normal. So its delay is in the AV node. So this is another patient with, again, first degree AV block. But this time, if you look at the AH is not too long, but HV is prolonged. HV normally is 55 millisecond, but it's much more longer here. So in this patient, first degree AV block is due to intra-His conduction. This patient may in future develop higher grade AV block. And these are the patients that we have to be careful about. And most likely this patient got EP study because probably has history of syncope or pre-syncope, and with a prolonged HV interval like that, a lot of times we will put permanent pacemaker in this group of patients. So here, again, if you look at AH is normal. After His, there is delay. So the delay is beyond His. So it's infra-His AV delay, a conduction delay causing the first degree AV block. First degree AV block, most of the time, it is symptom-free. It rarely can cause symptoms. Example is this patient. This is a patient actually had a pacemaker for intermittent AV block, but came back with exertional shortness of breath. And if you look at it, for some reason, the pacemaker was programmed in a funny way that it was not pacing. We fixed that part. That the PR is long and it's on the T wave. As the rate gets faster, the P is much closer to QRS complex. Basically, what happens in this kind of scenario, it develops some kind of pacemaker syndrome. That means the ventricle is contracting almost close to where the atrium is contracting. And this is the rate of 100. I'm sure if the rate goes to 120, P will become closer to QRS complex and it will cause symptom. In some patients, it causes symptom. This patient, 56, already had a pacemaker. I have one patient, young person, who was very, very symptomatic. And one of my partner many years ago put a pacemaker in, and that patient is totally symptom-free. But those are carefully selected patients with, we have definitely proven that this first degree AV block is causing the patient problem. And for quality of life, we can put pacemaker in. Otherwise, for first degree AV block, you don't want to put pacemaker in and you want to avoid at any cost. So second degree AV block, this is type 1 of Wenkeba. You can see there is, in this rhythm strip, PR interval little long and then gets longer and then gets blocked. And then the PR interval after the block is short. This is the key point to look at. That if you look at the PR interval before the block, longer and shorter, and that's Wenkeba AV block. If you look at the timing, this PR is 240 millisecond, 310 millisecond, non-conducted P wave, back to 240, 280, 310, 20, and then blocks. Wenkeba AV block. Again, most of these patients are asymptomatic and doesn't cause a problem. Where is the block site? And this is a patient where there is a P wave, QRS, P longer, QRS, and then there is a P wave here. How do I know this is a P wave? Look at QRS here. There is nothing. There is something here. So this didn't conduct. And if you put a his bundle catheter, you can see that AH is long, HB short, AH is longer, and then there is no H. That means the block happened before the his. That means the block is at the level of AV node. And that fits in with typical Wenkeba phenomena. And this patient, I'm sure if we exercise, the PR interval will shorten, AV conduction will improve. So this is super. But sometimes we can get infra his Wenkeba also. Like this patient, if we look at this patient, atrial electrogram, his bundle, and there are two his bundle actually, split his, and then it lengthens. That means this patient's Wenkeba actually is infra his, and then there is a block, and it blocked within his bundle. So this time the block is not here, the block is here. And these are the patients, a lot of them will end up, and that's where electrophysiology study can help, whether this patient needs pacemaker or not, that if there is split his or infra his heavy block and patient has symptom, somebody comes with syncope, everything looks fairly benign, Wenkeba heavy block, but you do a EP study, look at the conduction system, and it looks infra his block or split his, this patient get pacemaker. So this is one example that Wenkeba can happen beyond the AV node. Not common, but it is there. So this is a patient, type 2 AV block second degree. I mean, and we call this morbid type 2 second degree. If you look at PR, normal, then blocked, PR, and then so 2 to 1 AV block. This patient is presented with shortness of breath, not syncope. And so we can do the timing that P2, P666, there is some variation, and then QRS is related. So this is morbid type 2 second degree block. So the question is this one. This patient, if you look at this part of the ECG, 2 to 1 AV block, I have nothing else, but look at this patient. It's actually Wenkeba. So where is the block? So sometimes here is a situation, this patient, when it comes, this is 2 to 1 AV block with first degree. You are not committing yourself whether it's Morbis type 2 or Morbis type 1. And one of the distinction is block is at the level of the AV node. This patient, probably the block is at the level of the AV node because the behavior is Wenkeba. So if you don't want to commit yourself, you just go by the term 2 to 1 AV block. But then Morbis type 1, Morbis type 2, we usually use it when we use the term Morbis type 2, we say it's infra his block. But if you call it just 2 to 1, I don't think anybody should fault you for that. And that's the part when students sit in the exam and we want a specific answer. Sometimes we have to accept not so specific answers. So if a student gives me this answer, tells me that this is Morbis type 2 second degree AV block versus 2 to 1 AV block, I'll accept both of those answers as correct. Unless I get into discussion with that person about where is the location of the block. Is it suprahis, infrahis, is a narrow QRS, longer PR interval. It's interesting that infrahis block most of the time has shorter PR interval compared to suprahis block. Tushar, any comment on that, or you're fine with this?
Sir?
তোমার কোনো এটা তুমি জানতে চাচ্ছিল তো, তাই তো?
Sir,
Okay.
জি স্যার, এই মানে আমাদের আসলে এই 2:1 এভি ব্লক কোন জায়গাতে ফেলবো এবং হাউ টু কমেন্ট এন্ড হাউ টু অ্যাসেস এটা নিয়ে আসলে কার্ডিওলজি কনফিউশন ডিবেট এগুলো হয়। এই
Well,
জায়গাটা
I
একটু
mean,
আসলে স্যার
sure. I mean, it is 2:1 AV block. Then if we go into the location of the block, and I sometimes find Mobi's term very, very confusing to me. So Wenke IV block, second degree 2:1 AV block, and then you go to the location of the site. So if somebody tells me 2:1 heart block, I'll be happy with that. We don't push for it. So
is there any role of sir, is there any role of pharmacological intervention to assess whether it is type 1 or type 2 in 2:1, whether it goes more in favor of type 1 or goes more in favor of type 2
I mean,
with some
let's say,
pharmacological test?
okay. So the question, so this is the same patient that had 2:1 before this one. And you can see here is Wenkeba. First degree favorable baseline, prolonged block. If I give atropine to this patient, if it is infra his block, it will get worse. If I give atropine and it is block at the level of AV node, conduction will improve. So that's, if you want to try, that will be the one. The other thing we do, I'll put this patient on treadmill. And if on treadmill, AV conduction improves, that's most likely block at the level of AV node. If conduction worsens, then it is infra. And the reason is, you understand that in the beginning I said that at the level of his bundle, autonomic has little influence. So if I put someone on the treadmill or give atropine, their atrial rate will increase, but it will have no impact on the infrahis conduction. As a matter of fact, if the infrahis conduction is poor, as the sinus rate increases, AV conduction will worsen, and they develop more higher grade AV block. So this is a patient. You see, the PR interval is not very long. It's about 220 millisecond, but you can see P QRS, P no QRS, P QRS. So this is 2:1 AV block, and most probably Mobi's type 2 infrahis conduction. And this patient has bundle branch block, so that is more likely. But I have one ECG. This same patient ECG. Anybody comment on this one from the faculty?
This patient has got alternate LBB and RBB, sir, in V1.
Yes, this is the interesting part. I found this curious. So what happens? Look at this. P conducted with right bundle. P didn't conduct. P conduct, and then when it conducts with left bundle. So this patient has really bad conduction system disease. It has both right bundle and left bundle branch block alternating. But if you look suddenly, one may always think, well, there is AV block with PVC, but you have to look at this very carefully, that it's actually conducted, because the PQRS relation is consistent. Thank you. This patient, of course,
Sir,
I
this
mean,
patient should undergo pacemaker, I think.
yes,
Alternative bundle block.
no question. I mean, if this patient comes with syncope to the hospital, and I'm not doing pacemaker same day, I would probably put a temporary pacemaker in, because these are the patients that are more prone to develop intermittent high-grade AV block and asystole. A lot of times, patients come with pre-existing right bundle 2:1 AV block, or even complete heart block, good escape rate. We don't put temporary pacemaker in. We just put permanent, same day or next morning. But this is the kind of patient that if I have to wait, I'll put a temporary pacemaker in, if the patient has history of syncope. This is a dramatic ECG. This is a 59-year-old female with recurrent syncope, shows up in the ER with this ECG. Kind of interesting how patients are awake with a heart rate of 15. I mean, I have seen heart rate as low as 8 patients awake. So this is, of course, clearly complete heart block. But the question is, I was always curious whether this bit is conducted or not. And there's a possibility that this may be conducted, because the relation is pretty consistent. And the next day, patient's ECG is normal, but patient has underlying right bundle branch block, left interfascicular block, recurrent syncope. 59 in United States is a relatively young person, but she gets a pacemaker. This is not the case that I will look for Lyme disease, because Lyme disease will be for somebody who has pre-existing normal ECG and comes with AV block. And Lyme disease patients, once they develop heart block, they stay in heart block until the Lyme disease is treated. So this is not, this patient just got a pacemaker.
Sir, sir, just want to interrupt.
Yeah.
Many a times, it's our notion that the patient in complete heart block should remain in complete heart block throughout the time. Or many times, patient with complete heart block gets pacemaker, and the next follow-up, the patient comes up with normal sinus beats, normal rhythm. So, what's the mechanism for this?
Oh, so a lot of patients get intermittent complete heart block. Some patients are in permanent heart block, like this patient. You can see that intermittent complete heart block. It can be that the conduction system is diseased and there is some conduction and then it gets dinged up and then conduction recovers. It's just like left bundle. What we used to consider complete left bundle is actually not complete left bundle block. It's, there is some conduction. So this is another patient. This one, you can see there is no, the P wave and QRS have no relation. These are dramatic ECGs. That's why it's kind of unusual to find this kind of slow heartbeat. That heart rate of 12 with this patient. Of course, nothing else going on. She's a 77-year-old male with syncope with this heart rate. Complete heart block, gets a pacemaker. This patient's, this is 2020. And then you can see that prior ECG about 7 days ago had left bundle. So patient had a substrate for high heart block, pre-existing left bundle intermittent complete heart block. How about this one? This one, these are the tricky ones that if you suddenly look at it, you'll think, oh, this is sinus bradycardia with first degree block. But look carefully that the PR actually is changing. And then over here, I can see another P wave. So you have to, so when you look at it suddenly, it may look like sinus bradycardia with first degree block, but actually it's complete heart block with narrow QRS escape rhythm. This is a patient that I would probably, if needed, pacemaker is finally decided, I would not put a temporary pacemaker. I'll just go because it's, the QRS complex is narrow. So you can see this RR interval is regular, same patient, and the P and QRS have no relation. And the rhythm strip is much better when you do the timing. This is another one. If you look suddenly here and may think, oh, maybe this is conducted. But as you can look at the whole strip, you can see that it's totally dissociated. This is the same patient. Interesting. This is 28th of January, and then 29th, you can see underlying left bundle. If you look here, its escape beat is right bundle branch block, and the native was first degree block with left bundle. So these patients are the type that what is me sitting in the intensive care unit without a temporary pacemaker. So of course, the look at the age, 92-year-old. So how about this ECG? Anybody comment on this?
A fib with complete heart block, sir.
And why is that?
So there is a baseline is wavy. Something.
Yeah, but regular RR interval.
Yes, a junctional escape. Maybe there is retrograde.
Yes, so the question is that this is the thing for all the young doctors and everybody sitting there, that in atrial fibrillation, you expect the heart rate to be irregular. And if it is irregular, our convention is this is complete heart block. Any proof of it, Dr. Shafiq? Who commented on this?
Sir, I mean, Ajoy will say that.
Ajoy. So the fact that we call it complete heart block, is there any proof of it?
So it's the regular QRS complex, but there is no preceding.
Sure. So the question is, I was always curious. So we have been believing these things. How do we prove it? Because there is no way of proving or disproving it. But I have some ECGs. Look at this patient. This patient was wearing a Holter monitor at night, 9:20 p.m. There is some slowing of heart rate, so nothing. It can happen during sleep. But next day at 11:47, you can see that the heart rate is regular. And I did the timing. This
Yeah.
interval is
Hey.
1760, completely regular. So you assume that maybe there is intermittent high-grade AV block, right?
Yes, sir.
So this is 8 November 2017. Next day, patient goes into sinus rhythm, look at the high-grade AV block. So even though we have been thinking many years, yes, actually it correlates. And if you cardiovert those patients, some of them you'll find that they have complete heart block. So this patient actually has Mobius type 2 second degree AV block. Over here, Wenkeba, so it's 2-to-1 AV block. And then this is another one where it's not as prominent as the last one, but this looks kind of suspicious to me. I always get worried about when I see some degree of regularity. And if I measure it, it's 1400 milliseconds, 1460 milliseconds. And this is July 13th. July 15th, patient goes back to sinus rhythm, look at high-grade AV block on this patient. So the notion when it is regular and complete heart block actually is true.
So Rafique bhai, a question.
Yeah.
Oh, if it is an atrial fibrillation, slow ventricular rate.
Yes.
And the RR interval is irregular.
Yes.
And then P wave is replaced by fibrillatory waves, or we don't see the P waves at all.
Yes.
The question is, we will call it slow ventricular rate with the ventricular mechanism, or will how to differentiate? Because if the patient is good and the ventricular rate is slow, we just stop the drug and wait and watch.
Yes, absolutely. So if there is intrinsic conduction of fib wave, electrical activation from the atrium to the ventricle, RR interval is going to be irregular, even in the setting of slow ventricular response. And if they're on medicine, we stop it and wait and see what happens. But if they are not on medicine, then there is probably bad AV conduction. And eventually, a lot of those patients end up needing pacemaker. If somebody has heart rate of 35 with AFib, with not any AV node blocking drug, they have probably higher grade AV block.
And your other patient that showed junctional rhythm pretty regular,
Yes.
we need to be careful whether the patient is on digoxin or not.
Sure. I mean, so medication is something that we need to make sure. I mean, anybody coming with complete heart block in the setting of AFib or any other setting, we have to look at the medicine.
Yeah.
So this is the one. If you look at suddenly, so what is the rhythm? Rhythm, there is a P wave not conducted, P conducted probably because there is constant, but there is another P wave. So this is 3-to-1 conduction. I'm going to call it high grade AV block, maybe, but probably 3-to-1 conduction. There is some conduction. High grade will be maybe we have few more not conducted and some conduction. It's basically a question of semantics.
But if you do the EP study, Rafique bhai, on this patient, the last one, this will be an HV disease than AH disease.
I think so. Because if you look at when it conducts, the PR is normal.
Yep, exactly. So the PR normal gives me this, I think that this is more likely Mobius type 2.
Exactly. So below the his bundle.
Yeah. You know a person by the company he keeps.
Yeah. This is the patient that you don't want to give atropine, because if you give atropine, you increase the heart rate more, it will develop complete heart block. Because even now, bombarding his bundle with signal it cannot cope with. Yeah. So, okay. So this is an interesting case. So this is a patient. If you look at the date, 15 September, and then November gets mitral valve replacement. Anybody, any comment on this ECG?
It's a complete heart block. Yeah.
Yes, so that's what I thought. But how come this is irregular here? So the patient was sent to me because I was the EP doctor, and their question was, do you want to put a pacemaker in this person?
Was there a right bundle before?
Yes.
Or the patient had right bundle before?
Yeah.
Before the
Now,
surgery?
before the surgery. Now the right bundle. Right bundle is the left axis deviation, so it is old. So
Yeah.
what struck me, and then I came up with just a wild theory that maybe this is not complete heart block. Maybe there is conduction. So I'm going to go with that. So I looked at the intervals, the RR interval 1770, 1880, 1420, 1500. So it's shorter. And then I put the P waves. P are regular, 960, 950.
So
And I
it's a solid.
Yeah, so I came up with this wild theory that this P is blocked, this P conducted, this P prolonged, this P blocked, and I told the surgeon that this is Wankeba. And so I gambled on it. And guess what happened? Next day, you can see that after few days, it has improved.
Yeah, prolonged.
And,
Yeah,
and only prolonged PR.
Yeah.
And then I don't have the other ECGs, but it basically conduction came back to normal. But still, you know, this patient has a right bundle and left axis deviation. You have to be careful about these patients. If they're syncope or presyncope, we have to put a pacemaker in. What time is it now? So I think I thought that I have some. No, I didn't put those. I will do more ECGs next time, but I think I'm going to stop here today. If there is any question.
So Rafique bhai, this is a vexing problem for us, for the TAVR patients.
Yes.
And we see these AV delays and also new lip bundle. But
Yes.
we have a lower threshold for putting a pacemaker. Do you do like a pacemaker before TAVR if there is a jacked up conduction system, like bifascicular block with prolonged PR, and the patient is going for TAVR?
No, I mean, we are less nervous about AV block now than when it started, actually. So if immediately after there is new left bundle, then you start worrying, but we are, if they don't develop AV block, we just put heart monitor and follow them.
Yeah.
And
Yeah.
if there is no pre-existing clinical indication for pacemaker, we don't put a pacemaker. Yeah, I mean, it will be, if we keep doing that, then there is so much of our patient that eventually people will start putting pacemaker in everybody. So, so it's a situation, it's a place that we have to just look at. And I think that newer valves have less AV block, right, Hafiz?
Yes, yes. Particularly the Edwards valve are less requiring the pacemaker. Another question, Rafique, by these, we are doing sleep studies nowadays so often.
Yeah.
Called in. So your comment on the sleep apnea patients going into different kind of AV block, people panic about pacemaker. Many of them do not need pacemaker.
Well, I have patients up to 15-second pause, and I just said, I remember this Mel Gibson movie, Braveheart, that hold, wait, and wait, and wait until the enemy is on your face. No, we are not putting pacemakers in them. Even if they have history of syncope, somebody can have two different reasons for syncope, not slow heartbeat. So even with syncope at nighttime pause, no daytime pause, I try to prove whether they have this is the causing the problem. So and that's why you individualize these patients when you take care of them.
Yeah.
What should be our threshold for implantation of pacemaker in a patient with AV block who has obstructive sleep apnea? What should be our threshold point?
So, as I told you that I have had patients with pause up to 15 seconds, and we did not put pacemaker in because patient has no symptom at all. Now, if there is an 80-year-old person with history of syncope, left bundle branch block, and you are finding nighttime heart block, maybe you can make it. But if I have a 55-year-old and history of syncope, which can be from the history sounds like vasovagal syncope, and I find nighttime pause, I'm not going to put a pacemaker in. I'm going to wait. Not that I'm going to tell patient he will never need a pacemaker, but we need to prove this, the relationship, because I don't want to put a pacemaker in and patient comes back with recurrent syncope. And even if I put a pacemaker in, I'm going to make it very, very clear to the patient that, look, maybe you may benefit from pacemaker, but don't over expect that your symptom will be resolved.
And sir,
Yeah.
how long we wait for treating obstructive sleep apnea patients with this pause? So, is there any cutoff value, or is there any particular time frame that we can expect you take the treatment?
Yeah. Question is, how long do I hold off? Somebody who has no syncope and sleep apnea, they will keep having pauses at night. That doesn't mean that I have to put a pacemaker in. So if they have sleep apnea their whole of their life, they're going to have pauses at night and during sleep. But my pacemaker is not, there is no data that putting a pacemaker, I'm going to help that person.
Yeah, I think for the sleep apnea, it is important to correlate what time of the night it happened and what the patient was doing. And so it will be very difficult to convince an electrophysiologist to put a pacemaker if everything is happening during sleep, as you heard from Rafique bhai. So I have a question, Rafique bhai, for the acute coronary syndrome and AV block, it is sometimes a problem. What is your thought on putting a temporary wire? At what level you will consider to put a temporary wire if you are noticing 2-to-1 block, for example?
Well, it depends on the location.
Yeah.
If it is RCA disease, 2-to-1, I'm not going to put a temporary. It will resolve completely. If it is anterior and there is bundle branch block, those are the problem patients because
proximal LAD and
that conduction may not come back. So it depends on the location of the lesion and patient's history of MI or not.
This is actually an excellent point because we need to go back and probably read the blood supply of conduction system of the heart. Where does the SA node get blood supply? Where the AV node gets blood supply? The bundles get blood supply. This is very, very important to know. Because prox LAD can be a big problem if it's associated with the RCA. Sometimes we can get away with a preemptive atropine and not put a temporary wire. And this is so important, Rafique, by nowadays that we are doing the radial. The whole point is avoid the groin. And now we end up in problem. And it can be messy because interventionalists in general are very good in getting arterial, but particularly fellows, they make mess out of the vein excess. And in the middle of emergency, this can be a problem because patient is already anticoagulated.
Because before it could just go next to the arterial puncture, but now you have a problem.
Yep.
No, I think this is the part that with anterior LAD lesion and blood supply is important, and the AV node RCA, it affects the AV node, so his bundle is still active.
Yep.
Anyway, I hope this was of some good to you all. Any other questions?
Any question from the audience?
Currently, there is no such question in the chat box.
স্যার আসসালামু আলাইকুম
So there's a
হ্যাঁ
question.
আমাদের আমাদের হলো কি ইনফিরিয়র এমআই অথবা অ্যান্টিরিয়র এমআই সেপ্টাল এমআই যখনই হয় প্রায় হলো কি হার্ট ব্লক হয় আর হলো জাংশনাল এসকেপ রিদম থাকে কিন্তু প্রোপানথিলিন দিলে বা অ্যাট্রোপিন দিলে ওনাদের রেট বেড়ে যায় কিন্তু ওটা যদি ইনফ্রাহিজিয়ান হয় তাহলে রেসপন্ড করে তাহলে
যদি-
মানে
If it is inferior MI
হুম,
and right coronary anti-involvement, most of the time AV conduction will come back and they will respond to atropine. If it is anterior MI and involving LAD, it is atropine is actually going to make it worse.
Yeah.
And most of the time they will need temporary pacing, and if not, subsequently permanent pacemaker.
আরেকটা জিনিস হলো যে আমাদের যখন এলভিএবি কারোর যদি কন্ডাকশন সিস্টেম ইসকেমিয়ার জন্য হয় যার এমআই নাই তার যদি পরে এমআই হয়ে যায় ওই এলভিএবির মধ্যে তাহলে কি ওনাকে করা যাবে থ্রোম্বোলাইসিস করা যাবে
Sure. Look, the pre-existing left bundle branch block, somebody gets LAD dilation, it's not necessarily true that it is going to make the conduction system any worse. So we will just treat them like any other patient.
আর হলো কি আর আমাদের এসভিটি তো আচ্ছা আর হলো কি কারোর যদি ন্যারো কমপ্লেক্স ট্যাকিকার্ডিয়া থাকে ওইটা যদি এসভিটি নাও হয় তবু কি অ্যাডিনোসিনে রেসপন্ড করতে পারে
Yeah, narrow keyword, if it is SVT, it will respond. If it is not SVT, like atrial flutter, atrial fibrillation, then it is unlikely to terminate the tachycardia. It may slow it down temporarily. Some atrial tachycardia may respond to adenosine. The other thing is that one narrow QRS tachycardia, which is not SVT but looks like SVT, fascicular VT, can respond to adenosine actually and stop.
ফেসিকুলার ভিটি কি হলো ফেসিকুলার ভিটি কি কন্ডাকশন সিস্টেম ইসকেমিয়ার জন্য হয়
No, it's a reentry. Some ischemic heart disease patient may develop fascicular VT, but it's actually a re-entrant mechanism in the fascicle.
আর হলো কি আমাদের ইয়েস্টারডেও একটা কনফিউজিং ইসিজি ছিল ওই ইসিজি যদি আমাকে অ্যালাউ করেন তাহলে দেখাতে পারি
Sure, you can send it to us and we can look at it.
হ্যাঁ এটা সেন্ড কি করে স্যার সেন্ড কি করে করে
তুষার একটু তুমি করো তো পরে বলে দিও। Okay.
Actually, Rafique bhai,
Yes.
it is a good thing that in future, maybe if the participants wants to bring any EKG,
Yes.
maybe we can allow some time if they have any EKG, but they need to contact the Tushar for the how to upload and how to reach to
Yes.
us.
Sir, just for the sake of discussion, many a times we have patients who cannot afford pacemaker on complete heart block, and usual practice is to give theophylline and propantheline so that the rate increases. How do you explain this practice, sir?
হ্যাঁ সেটা তো তোমার কোভিডে যে ওষুধও কাজ করে বুঝছো এখন তারপরে কথা হলো যে even the work not everybody is going to die in every disease. If you take cancer, if you take heart disease patient, even if you don't do stenting of an artery, a lot of people will survive, but theophylline we don't use it. I mean I know it's a fairly common practice in Bangladesh, but we don't.
So Rafique bhai, maybe because he brought up this issue, there is a thing called the chronic stable complete heart block, right?
Yeah.
and there are many underlying causes. If the stable chronic complete heart block and QRS narrow, and the patient is asymptomatic, and
Yeah.
the patient thinks that I don't have any symptoms, why I need pacemaker, then it is a problem, right?
No, I mean, if you look at complete heart block patient, congenital complete heart block patient,
Yes.
we wait. And a lot of times we keep waiting and put pacemaker when you start seeing echo evidence of left ventricle is dilating. Yeah. So if somebody has, let's say, inferior MI and had a complete heart block with junctional escape beat, this is similar to congenital complete heart block patient. And if the patient cannot afford it, that,
Yeah.
but
স্যার ওই ক্রনিক কমপ্লিট হার্ট ব্লক পেশেন্ট অ্যাসিমটোমেটিক মানে কথাটার মধ্যে একটু ভেগনেস আছে না, কারণ পেশেন্ট যদি পরিশ্রম করে, সে যদি জোরে হাঁটে বা একটু এক্সারসাইজ করে, তার তো ফ্যাটিগিবিলিটি ডেভেলপ করে, এটাও তো একটা সিমটম।
oh yeah, no, when you say asymptomatic, there are two ways of asking for symptom. One, আপনার কোনো অসুবিধা আছে কিনা, বলবেন না কোনো প্রবলেম নাই, তাছাড়া একতলা হাঁটে উঠতে পারবেন না, একতলা হাঁটে দুইবার থামতে হবে, so এটা একটা সিমটম। আবার আরেক ধরনের রোগী আছে, আমি যেগুলোকে প্রশ্নই জিজ্ঞেস করি না, মনে করো 31 বছরের মেয়ে আসছে, ওকে যদি জিজ্ঞেস চেস্ট পেন আছে, হ্যাঁ, বুক ধরপড় করে, হ্যাঁ, নিঃশ্বাস কষ্ট হয়, হ্যাঁ, সবকিছু সিমটম আছে, বুঝছো? So, I mean, that's why the clinical thing is important. As you said, that patient may say, that's why the echo is very good. Before, we used to do chest x-ray. If the echo shows there is dilatation of the ventricle, that means it's time that you definitely have to put a pacemaker.
So, Rohit, any role of making them walk and see the heart rate response in
Yeah.
those situations?
Sure. I mean, you can do a 6-minute walk test, or you can put them on treadmill to see what happens. And the other thing that you look at is what is the discrepancy between the atrial rate and the ventricular rate.
Yeah.
If the ventricular rate is adequate, the atrial rate would not go up as much because body thinks I am fine with that rate. However, if somebody exercises, the ventricular rate goes to 70, but the atrial rate is 140. That means the body is saying, I need a little bit more heart rate. And the sinus node is the marker for that. So that's another thing that you can look at. All right, thank you.
কোশ্চেন হলো কি অ্যাট্রিয়াল ফিব্রিলেশন অথবা হলো কি এসভিটি উইথ এলভিএবি হলে পরে লেফট বান্ডল ব্রাঞ্চ ব্লক। তাহলে আমাদের কালকে যে রোগী ছিল ওনার হলো কি অ্যান্টিরিয়র এমআই ছিল, এলভিএ প্যাটার্ন ছিল, আর জাংশনাল ট্যাকিকার্ডিয়া ছিল বা সুপ্রাভেন্ট্রিকুলার ট্যাকিকার্ডিয়া ছিল। তো সুপ্রাভেন্ট্রিকুলার ট্যাকিকার্ডিয়ার সাথে এলভিএবি আমি এত কমনলি দেখি নাই। আমি ওটাকে প্রথমে এ ভাবতেছিলাম, কারণ ওনার কমপ্লেক্স গুলো খুবই বড় বড় ছিল আর বোঝা যাচ্ছিল না যে সমান কিনা। তাহলে এই ক্ষেত্রে কি এরকম ওনার এটা কি কমন অ্যান্টিরিয়র এমআইতে জাংশনাল ট্যাকিকার্ডিয়া?
Yeah. Okay, let's do this. Next session, please bring your ECGs and bring the case. We will talk about it because it will be good to look at the ECGs and discuss. So why don't you make up a case presentation of that patient and then talk to Tushar or Atahar, Prof. Atahar Ali, and then you can show it to us and we'll talk about it. What do you think of that?
That's a good idea. So when we put
Yes, sir.
our next lecture session, we'll request the participants to give
No,
the
what's the name? Dhriti.
Yes, sir. Yes, sir.
ধৃতি, তুমি আমার সঙ্গে যোগাযোগ করো, আমি তোমার এটা মানে নেক্সট সেশন আমরা মানে দেখাবো আর কি।
জি স্যার, অবশ্যই।
Yeah, you can present the case. It will be good for you and for all of us.
Yes,
ঠিক
sir.
আছে।
Thank you, Rafique Ahmed, sir, for again the brief but informative and most to the point presentation on FE block. Before we wrap up, I'd like to request Abdul Jamil sir to say his experience of this lecture.
তুষার একটু জাস্ট সরি একটু এসএ ব্লকটা কি করা যায় নাকি স্যারের যদি বলতেন আবার এবি কন্ডাকশন হলো আমরা কি সাইনোএট্রিয়াল ব্লক কি
আমরা স্যার এসএ ব্লকটা আসলে বলি নাই,
হ্যাঁ
এসএ ব্লক আসলে বলা হয়নি স্যার।
না
ওইটা next, I think we should do 600 syndrome or
সাথে বান্ডেল
as a
ব্লক স্যার, হ্যাঁ
at
যেটা
different time.
জি স্যার জি স্যার জি
আর
Okay.
আসলে রফিক ভাই এসে ব্লক particularly without showing examples and EKG, it is not easy to give to
Yeah.
just say things.
Exactly.
Jamil sir, are you here with us?
Yeah,
Sir, please share your experience of this lecture session.
I, Honorable Rafique sir, Hafiz bhai, Atahar bhai, and all other learned participants. Actually, I always admire Rafique sir's lecture, as from every lecture we get some tips, newer things within the older lecture. And it was an excellent lecture of different kind of AV block. Thank you, sir.
Thank you, sir. I'd like to request Atahar Ali sir to say some word about the presentation and conclude the session. Atahar Ali sir.
but before that, Dr. Amal Chowdhury, Amalda. So thank you, Dr. Tushar. Very special lecture. Rafique sir's lecture is always special, and I enjoy always. This is a very special area of my learning. I always learn many things from Rafique sir, and this lecture was very special. I learned a lot, very practical and easy of daily life. Really, there are many tips for me. I personally learned a lot. So thanks everybody for participating, and our next lecture date will be, Tushar, you can declare the date, and I hope Hafiz bhai will be the next speaker. That is the next sessions.
What day is that?
Tushar.
Sir, as it is already 10:40 p.m. Bangladesh time, and we have a very lively lecture session.
Tushar, next date. That is the Hafiz bhai will be the speaker.
Sir, আমাদের next lecture sessionটা হবে হচ্ছে স্যার second Sunday of September. That means it's on the, I'm just telling you this,
14th or 7th? 14th.
14th sir.
14th, yeah, I should be fine.
হ্যাঁ, কারণ আপনি 7th পর্যন্ত বোধহয় আপনি স্যার ব্যস্ত থাকবেন, আপনি বলেছিলেন। If
Me,
I'm not-
yes, yeah, Madrid.
হ্যাঁ, so 14th, so 14th will be in Dhaka,
that's
I
fine.
guess. 14th you will be in Dhaka, I guess. Hello.
ঠিক আছে Tushar.
Okay, sir. Thank you all, and thank you our scientific partner, Vaccine Pharmaceuticals, for supporting us technically. And we'll again meet on 14th of September with our next session on ECG. Thank you all.
We did cross 50 today. So next
Right.
goal is 100.
Okay. Okay, sir. Thank you.
Tushar.